Hello, hello. Good to see you all for this interesting discussion on vasopressor therapy in the critically ill. My name is Jean-Louis Vincent. I will have the pleasure to moderate it, and perhaps we could go for a very quick round of introductions, starting with you, Jan. No.
Intensive care doctor in New York.
Can you say it again because your microphone was...
Oh, good morning. I'm Jan Bakker. I work in the intensive care in New York, NYU Langone.
Chris?
Hello, everyone. Christopher Seymour from the University of Pittsburgh, medical intensivist.
Jean-Louis?
Hello, everyone. I am Jean-Louis Teboul from Paris, France. I am a medical intensivist.
Frank?
And good evening. This is Frank Van Haren. I'm from Canberra in Australia.
Very good. So let's go with relatively short questions and answers. But an obvious first question is, when do we start vasopressor support? Perhaps giving a blood pressure level, although we will go back to that in just a moment. But an essential question is, very often, especially in septic shock, fluids first and then vasopressors, or fluids and vasopressors together? What would be your strategy in a few words? Jan?
Well, it depends on the situation of the patient. So if they have a low blood pressure, but they are talking and they are answering questions, I'm much less concerned. But if they have, for instance, a bad peripheral circulation or not responding at all, then I would start fluids and vasopressors at the same time. If I think they're really hypovolemic, like a history of diarrhea and vomiting, I would start always fluids. If I don't have that history and the blood pressure is indeed very low, I would start vasopressors first. So that's a general guideline for me. The context of the patient is always more important than the blood pressure, the number itself.
Okay, Chris?
Yeah, I would agree with what Jan has suggested. I usually try to start thinking about the history of the patient. If I know that there's been blood loss or a recent surgery or history of volume loss, then of course that will guide my initial choice for fluids. I think there are specific scenarios where pressors could be started first, whether it's trauma or neurologic injury. And I entirely agree with Jan to treat the patient, not the number. And to use the end organ signs of perfusion to guide our level of concern.
Jean-Louis?
I agree with this. Of course, it depends on the patient. It depends on the situation, on the context. If there are very evident signs of hypovolemia, I would first correct hypovolemia by giving fluids. But sometimes we have a vasoplegic state, and I would give vasopressors. In general, patients receive already fluids by emergency physicians, pre-hospital or hospital emergency physicians. So when we are called in my ICU, in general, patients already receive fluids. So we start vasopressors if the mean arterial pressure is not okay, or if we have the feeling that there is some vasodilatation. And as you know, I like to identify vasodilatation as a low diastolic blood pressure. So in my experience, I first give fluids, essentially to correct signs of hypovolemia. And if the diastolic arterial pressure is low, I will add vasopressors.
All right, Frank?
I have to say I agree with the previous speakers. I think some really important points have been made. the history will tell you something about real hypovolemia. And I just would like to point out that I don't consider sepsis or septic shock to be states of hypovolemia, but as Jean-Louis Teboul is saying, it's much more a vasodilatory state. We've also recently shown that fluid resuscitation early in sepsis actually can worsen the shock state by further vasodilating, by vasodilating effect. And after that, you need more noradrenaline than if you didn't give fluid in the first place in septic patients. So I'm quite concerned about fluid resuscitation, and certainly aggressive fluid resuscitation early on in sepsis and septic shock. And I would much rather, if it's clear to me that it's vasodilatory shock, I would much rather start vasopressors early in those situations.
So the situation has changed from my early training period, where we used to give fluids first and add vasopressors only when the patient was not responding well to fluids. It seems that we have a consensus on this. Now, may I ask you what the target is? And Jan already addressed the question a little bit, but when we read some methods in some papers, we read that, especially in septic shock, people aimed as a mean arterial pressure of 65 millimeters of mercury, and that was the goal. Now, is it the only goal? Is it the essential goal? Yes or no? Who would agree? Who would disagree? Raise your hand. But if you don't raise your hand, then Jean-Louis will be the one who will take that question first. And then Frank. Jean-Louis?
Yeah,
go ahead.
We have some benefits and some risks. So also for the target, if you choose 65, you are close to the critical point of the autoregulation relationship. So the risk is a new episode of shock with a decrease, a fall in blood pressure that you cannot anticipate. But the benefit is not to give too much vasopressors. If you are far from this limit, if you are 80, for example, 85, the benefit is to avoid new episode of hypotension. You are more comfortable, but the risk is excessive vasopressor load. So there is a balance between the risk of excessive vasopressor load and the risk of hypotension if you are too close of the low limit of autoregulation plateau.
Okay.
So
thank you.
Depends on the patient, of course, and I would say 75 would be better for me.
So okay, well, I hope we will speak more about individualization, but I don't want people to agree all with the others, because that's boring. So try to have something more personal. Frank, and then Chris, and then Jan.
So I do agree, but I agree with the personalized approach, Jean-Louis. And I think this is the future. And I think we're right in the middle of trying to prove that that's the future. What I'm talking about in terms of personalized blood pressure is looking at a patient's blood pressure before they came to us. So the patient's blood pressure in the community, or maybe at the end of a previous admission after he was well again. And that blood pressure, if you take that and put that in a formula or an algorithm and make the target, what a recent study showed recently in a Blue Journal is that if you closer to the patient's own blood pressure, so if there's less deficit compared to what the patient's own blood pressure is while the patient is in ICU, you have far less acute kidney injury in effect, there was a signal in that study towards less mortality. Now that needs to be prospectively tested now, that hypothesis, but I think we have a strong hypothesis now to really look at individualized blood pressure based on pre-morbid blood pressure readings rather than just a one-size-fits-all.
Yeah, very good. Now, very often we miss this information, but I fully agree that this paper in the Blue Journal is very interesting, and that's what the anesthesiologists now do in the operating room as well. Chris?
Brings up a good point. I do think formulas are a little bit more difficult to use at the bedside for most clinicians, but the concept is valid. So in the US, we have a number of patients with alcohol use disorder, perhaps a cirrhotic. By characterizing these patients by their underlying comorbidities, we can get a sense for what that target might be, meaning in the patient with significant liver disease, perhaps a lower target, whereas known hypertension with a variety of meds that they might take in the outpatient space, we might shoot a little higher.
Okay. And Jan, something to add from what you said before?
Well, to be honest, I don't agree.
Good.
As I said before, it's the context of the patient. And I think it's very important to take into account whether there is adequate blood flow, apart from the pressure. Because if you have a high cardiac output and you're in a fully vasodilated state, the only problem the organs have is to regulate the perfusion of the organ, but that's very limited because they're in a vasodilated state. What we showed in the small study we did with the colleagues from Austria, if you have abnormal periphery and so you're vasoconstricted, then you vasoconstrict everywhere. But if you're vasodilated, the perfusion of your abdominal organs is quite okay. And just as an example, we had a patient in the emergency room with a mean arterial pressure of 45 on an arterial line, not perfusing at all. And we had to start CPR because his pupils were wide open. There was no brain perfusion. 2 hours later, he was sitting upright, making jokes with a blood pressure of 45 still. And so if you're in a low pressure situation because you have no flow, that's completely different than when you're in a high flow situation with a low pressure. So I think that the context of the patient is really important. And the problem arises when the patient is sedated, because then you have no clue. But as long as the patient is sedated and responsive, as we wrote many years ago, I have no problem with a mean arterial pressure of 45. But they need to be awake and responsive. If not, then I go for at least 60, just like Jean-Louis Thibault.
So we mentioned the skin, the brain. Nobody mentioned urine, huh? But we agree, we have to look at urine as well. No? Jan, you say no? No urine? You don't look at urine?
Look at urine, no. Because what happens, at least what happens in the practice, the patient doesn't pee because the kidney is injured, and they start pushing fluids and furosemide to make the kidney pee, and I don't think that makes any difference. If you give fluids and the patient starts peeing, that's great. But if the patient doesn't pee, you give fluids, you increase the blood pressure. We tried in the Andromeda trial, and they still don't pee, then they don't pee.
No, but it could be the other way around. If the patient is making urine, it could be somewhat reassuring, couldn't it? Okay, very briefly, an arterial catheter for every hypotensive patient. Do we insert always an arterial catheter, or sometimes not when it seems that perhaps it's very transient? Chris, you seem dubitative.
I actually sometimes use arterial line as a way to spare the patient a central line. So we often have issues with measurement accuracy here in the US, whether it's obesity or vascular disease. We haven't trained all of our practitioners to do completely accurate blood pressure measurements using a cuff. And so by putting in the A line, sometimes we can uncover new information that we didn't know, meaning the patient actually wasn't hypotensive and they don't need the vasopressor and might not need the central line. So I like to do it first.
Okay. Another comment on that, or shall we move to the next? Yeah, Jean-Louis, quickly.
Very quickly, I agree with everyone that we need to individualize our target, but we have also to think about CVP, central venous pressure. And sometimes CVP is low, okay. Sometimes CVP is high, and we should take into account this high value, because what is important for perfusion of organs is the difference between the upstream pressure, which is reflected by MAP, and the downstream pressure, which is more or less reflected by CVP. So in case of high CVP, we should take into account CVP and maybe increase a little bit the MAP target.
Yeah, Frank?
Can I very quickly say that I completely agree, and I didn't say that earlier to not make it too complicated, but the Blue Journal paper I referred to, actually, Jean-Louis Thibault looked at mean perfusion pressure and not at blood pressure. So in that paper, a pre-morbid mean perfusion pressure was estimated or obtained, and then the mean perfusion pressure in intensive care was compared with that pre-existing pressure. And I completely agree, the CVP is very important. When the CVP is high and the blood pressure is the same, then you're right, the perfusion pressure is lower, and that needs to be taken into account as well. Thank you for raising that, Jean-Louis.
Okay. Now, we are just at the middle of our discussion, so now it's time to speak about the drug or the product or the molecule we would use first, and I'm sure there will be a consensus to say that norepinephrine or noradrenaline would be the first agent. I'd like to know if some could use another agent as a first line agent. For instance, Chris, in the US, I know in some emergency departments, they like to use dopamine, perhaps in part because it's already mixed in a solution that is ready to use. What is your take on that? And then Jan.
Yeah, so I think that's probably true, but changing, Jean-Louis. So dopamine as a first line agent, because it's available and at the ready in perhaps a code cart, is something we would have done maybe more 10 years ago. I think in general, norepinephrine is absolutely the first choice, regardless of patient location here when we have shock.
Okay, Jan, is it your experience as well?
Yeah, well, over here, the cardiac people, especially cardiologists, still like dopamine a lot. But the ICUs have all switched to norepinephrine as a first-line drug in patients. And
Yeah,
interesting, some hospitals use the microgram per kilo per minute, and others use micrograms per minute. That's also an interesting discussion.
What should we do is the question that our attendees may have. What should we do?
You mean for the dosing? Or?
No, before, in terms of choice of agent. Because when a cardiologist starts dopamine, would you say, okay, you are a cardiologist, that's fine? Or do you try to convince the cardiologist that he or she should not start with dopamine? No.
Well, after following the study that you did with Danielle, I've never used dopamine anymore. And so I only use norepinephrine and epinephrine also only in very acute cases with low heart rate and very low blood pressure and stuff like that. So that's an emergency drug for me. They like phenylephrine here, but there is so few data on phenylephrine, and norepinephrine is so active and so, let's say, beneficial or adequate in the majority that I think we should use norepinephrine first.
Jean-Louis, some people in France like adrenaline, epinephrine. Is it okay with you?
Everyone uses norepinephrine.
Okay, okay. And Frank, in your part of the world, some people sometimes use very strong vasopressors, indeed, phenylephrine or even metaraminol, aramine. What do you think about it?
Well, Jean-Louis, you're absolutely correct, and it continues to surprise me as well. There seems to be the use of metaraminol seems to be to try and evade putting in a central line. So if you can support the patient for a short period of time with metaraminol, then maybe you don't need a central line and you don't need noradrenaline. That seems to be the reasoning behind it. It's on my to-do list to properly study that, because I think there's very, very limited data what happens with these patients and how many of these patients then need to be transferred to noradrenaline afterwards, and how many patients just do well with a bit of metaraminol for a couple of hours. I think it's a very anesthetic approach, not so much an intensive care approach, but you're right, it's quite common here in Australia, and I don't think there's great evidence for it, but yeah, it's used.
Well, as Jean-Louis alluded to before, there is a risk of excessive vasoconstriction and a risk of decrease in blood flow if you are too liberal with the use of very strong vasopressor agents, right, Jean-Louis? That's what you meant?
Yeah. I think that the risks are limited with norepinephrine compared to epinephrine. Epinephrine.
Yeah, okay, very good. Okay, very good. Now, people very often raise the question, when do you start a second vasopressor? In the US, they often speak about it. On how many vasopressors is the patient? 1 or 2? And sometimes the patient is on a rather small dose of norepinephrine, but some vasopressin, let's say, or another substance with vasopressor properties, and they call it 2 vasopressors as if it was a sign of severity. So, Chris, what do you think?
Point. So, I mean, there's some face validity that if a patient's requiring multiple drugs to maintain perfusion, they're likely sicker than none. But there's been sort of an interesting pattern of when to start the second drug, in part because I recall the Surviving Excessive campaign document has a specific threshold. And that makes it easier for clinicians to say, oh, well, at 0.17 mics per kg per minute of Levovet, I'm going to start vaso. That convention has gone away a bit, in part because, at least in the US, vasopressin has become quite expensive. And so there are many health systems that are seeking ways to avoid the use of the drug at all costs, except perhaps in perioperative patients. And so as a result, we end up with patients on very high amounts of just norepinephrine, far more than we used to. So I think things have changed a bit.
Okay, well, the next question will be about vasopressin more specifically, but about this question of a second vasopressor, Jan, and then Frank. Frank, yeah, okay.
Well, to be honest, I have ever not much seen patients that really need a lot of vasopressors. It's a quite rare thing unless you have a threshold. And so, for instance, in one of the hospitals that I've worked, they have a threshold for maximum norepinephrine. And so whenever the patient receives more than 30 micrograms per minute, they say that's maximum norepinephrine. And I always explain, so the maximum norepinephrine for a 100 kilo patient is much lower than for a 50 kilo patient. So that, I don't think that makes any sense. But once I reach 1 microgram per kilo per minute, around that time, I usually start a second vasopressor.
Okay, yeah, that's a long. Yeah, it gets along with what Chris was saying about the fixed maximal dose of an agent. Okay, vasopressin. Some people say, and that's what we used to say with the Surviving Sepsis campaign, if the patient seems to be quite hypotensive with relatively strong vasopressor support, then we add vasopressin. But there is quite a bit of evidence out there that the very early use of vasopressin could be helpful to help the microcirculation, perhaps to help the kidneys a little bit. So there are some arguments to give it early. So I'd like to ask you, early, late, or not at all? We already heard about the availability of vasopressin, the costs. We would like to hear more about it. What is the Australian attitude and your attitude in particular, Frank?
Right. What I see is that it's often used as norepinephrine sparing treatment. So once the norepinephrine or noradrenaline goes up very high, vasopressin is added. In my mind, that's not a logical thing to do. I think when you look at the studies, the benefit is probably more when the noradrenaline is not so high. When you have very high noradrenaline levels and you add vasopressin, one of the things we've shown a long time ago is that the gastrointestinal perfusion gets a lot worse and you get more complications related to vasopressin. So I think if you wanted to use vasopressin in addition to a noradrenaline, maybe as a noradrenaline sparing drug, you probably should give it much earlier when the noradrenaline doses are lower and not so much as a last resort drug right at the end. But having said that, that is still often how people use it. They add it right at the end if they don't know what to do anymore.
Mm-hmm. Jean-Louis?
To be honest, until recently, we had only norepinephrine in France. We couldn't use vasopressin, and we received the approval of vasopressin use very recently. And so I will change my attitude, probably. And I totally agree with Frank, saying that probably the best option for vasopressin is to give early in the course of the disease, because there are some physiological reasons, pharmacological reasons. You can spare some doses of norepinephrine. We can avoid excessive doses of norepinephrine. So I think that low doses of norepinephrine plus low doses of vasopressin, maybe plus low doses of angiotensin 2, could be probably the best option, I think. But I did not use yet because it was not approved in France. It was recently approved, so we will change our attitude. And maybe next year I will give my experience about this.
Now, should we really consider vasopressin as another vasopressor agent, or should we consider it, that's what I would advocate, consider it as a hormone which has vasopressor properties, of course, hence its name, but it's not just one versus another, and perhaps not just to spare, to limit the doses of norepinephrine. Perhaps there are some other advantages. What do you think, Jan? Jan, are you there? Are you there?
Yeah, I'm thinking, because I mean, you make a very I'm usually silent when I think. No, you make a very important point. It's not one or the other. For instance, if a patient is extremely tachycardic, I tend to use vasopressin much earlier to spare, if you can, spare some norepinephrine. But if the patient is not very tachycardic and is on norepinephrine, and not incredibly high doses, I don't tend to vasopressin. In the protocol we have, all patients start with vasopressin once you hit 30 micrograms per minute. That's a protocol, and there's no shortage of vasopressin. Nobody tells you not to use it, and so that's how it's used in the clinical practice over here.
Okay. Chris?
Is that we don't have any sort of readout that says a patient's going to be vasopressin responsive. There's no molecule or biomarker to measure or clinical symptom or sign that says, yeah, that's the right patient. And so it's a bit of a wild west, and hospitals and health systems are sort of developing their own approaches here, as described.
Yeah, very good comment. And we would love to have better ways to identify the patient who could benefit, no? Frank, do you agree with that? Do we all agree on this particular element?
And even if we were, I mean, we've done that in the past. If you were to measure the levels in patients, which is very difficult to measure, most labs can't do it. Even then, if patients are shown to be deficient, it doesn't actually tell you whether and how these patients are going to respond to vasopressin. So there is no measurement that you can do to to individualize the vasopressin choice. Talking about individualizing, you might remember that from the FAST study, there was an interesting post-hoc pharmacogenomics study, and they looked at single nucleotide polymorphisms, where some patients who had that SNP had significantly more side effects from vasopressin compared to patients who didn't have that SNP. So, I mean, talking about individualizing, and that may be the future, maybe in the future we'll be able to tell which patients at least could have more side effects of vasopressin.
Yeah, Chris, very good point. Yeah,
Just
Chris.
one other interesting point about vasopressin for our group is that there are downstream consequences to adding on a second or third pressor, and it relates in some ways to corticosteroids. Not to change the topic of the discussion, but clinicians tend to do other things for the patients once the patient is now on two pressors. Maybe they won't transport them for additional CAT scans because of the risk. Maybe they'll be more inclined to add hydrocortisone or other steroids. So there are consequences besides just the physiology and the shock resolution.
Okay. Now we are reaching the end of our discussion here, but maybe you would like to add a couple of words about perhaps some other substances, and in particular angiotensin. It may be quite costly, but what is the place of angiotensin? Who has the most experience? Jan or Chris, maybe? In the US, it's more available than on other continents. Jan, maybe?
We have
Angiotensin?
angiotensin available. I've not yet met any patient where I felt that I would need it. I mean, the theoretical arguments for instance, kidney perfusion are valid, but up until now, I've not been in trouble with the simple combination of norepinephrine and adding some vasopressin later on. So for now, I've never used it.
Chris?
Yeah, so same thing here. Giapreza, as it's called, or angiotensin 2, is not on formulary at our health system. The CEO and the C-suite have decided with our pharmacy colleagues that the potential cost does not balance out with the patient benefits. So we've never used it here.
Jean-Louis and Frank, any comment, experience, recommendation? Frank?
No experience, but I would say that while the studies show that the blood pressure goes up and some of the perfusion goes up, there's not really any evidence that patient-centered outcomes improve. And I think, and I'm not sure if these studies are going to be conducted after the studies that have been done so far, but it doesn't really, I think, give enough incentive. It's an expensive drug, and it doesn't give enough incentive to start using it if we don't actually know that patients' outcomes will be better.
Well, yeah, but on the other hand, do we have any any evidence that any of these agents improves outcomes. We haven't spoken about dobutamine because it's not really the point of our discussion, but it's the same thing. And for vasopressin, there is no evidence, etc., etc., etc. So before we can see a real impact on outcome, it may take a while. Any last comment? Because I think we have had a nice discussion. It's relatively short, but the discussion should not exceed 35 minutes. But we have 1 minute left for Jan. You raised your hand.
Yeah, Jean-Louis Bull also raised. I think what's important is to, at least that's how I address it in clinical practice, is you create an environment where you have the, let's say, best possibilities for the patient to survive. And one of them is blood pressure and blood flow and all that stuff. When you talk about studies improving outcome is such a complex, let's say, mechanism that only in extremely low blood pressure, a blood pressure will have an impact. And so I don't believe in epidemiological numbers. I try to get an individual number for the patient and create the environment where the chances of survival are best. Because there's much more than blood pressure, of course.
That sounds like a very good end to our discussion, gentlemen. And as I say, gentlemen, it hurts there because I realize there is no lady in the group. Sorry about that. Nevertheless, we had good discussions. So thank you very much. And we will see you later. Hopefully not too late from now. Take care. Thank you.